So let's move on. There is a lot of new information about frontline therapy. As we've mentioned already, one of the key trials that has been presented is the CASSIOPEIA trial. We also have the MAIA trial. We also have the wonderful information that sub-Q Dara is available versus IV. We also have a very interesting study that looks at the merits of autologous transplant in the frontline setting. And then we have some early data about what really is the impact of having the 1114 translocation. So I'm just going to go briefly through these recent presentations and publications. I say both because in the case of the CASSIOPEIA trial, which was presented at ASCO, during the presentation, the publication was also released online in the Lancet, and so this is one of the first times that we had both happening at once.
And Philippe made mention of it. Yes. He's looking at his watch saying, I think it's coming online right now.
I'm presenting it now, and it's hitting publication right now. And so obviously he's so familiar with the results. But clearly, as you might expect, there is a decisive benefit to adding Daratumumab to the Velcade, thalidomide, and dexamethasone combination. And it's obvious in the amount of MRD negativity. It's also evident in terms of the progression-free survival. But it's interesting also that for patients who did achieve a deep response, that was important, whichever arm of the study that they were on. And so I'll look forward to your further comments on that, Philippe. The MAIA study, Daratumumab plus Lenalidomide and Dex, this actually was published in the New England Journal. We've had a rapid movement of data from presentation to publications, this one in the New England Journal, and as you might expect in this case, a clear benefit of the triplet versus the doublet. So we have those options in the frontline setting. These are the data that just show that Daratumumab given subcutaneously is equivalent to IV. Interestingly, even slightly better, you know, and it may be that the sub-Q has a slightly longer exposure, and you can see the pharmacokinetics there, but obviously very safe in the sub-Q administration. Then the interesting thing presented from the Italian team was the results of the Forte trial. And the interesting thing which I made note of was that the KRD combination, if administered for 12 cycles, gave equivalent outcomes. For example, I've highlighted there the MRD level versus KRD plus autologous stem cell transplant. And so this was particularly helpful in the high-risk setting. So I'll be interested in hearing what you think about this in terms of the role of transplant in the frontline setting. And then just a little bit of data to say that we are understanding that patients with 1114, they do seem to do better with an IMiD proteasome inhibitor combo and also with autologous stem cell transplant. But now we will wait to see how will the use of venetoclax, the BCL2 inhibitor, influence our selection for treatment. And so perhaps I can come to you, Philippe, first on this one. So first of all, what is your bottom line for the CASSIOPEIA study? And then how do you see this impacting our choice of therapy in the frontline setting?
Well, up to now, not only in the US, but also in Europe, before stem cell transplantation, we were using a triplet combination with a PI and an IMiD. VTd is standard of care in Europe, but in the US, VRd is standard of care. So we wanted to look at the impact of the addition of a monoclonal antibody, Daratumumab, and the primary endpoint was the stringent CR rate after consolidation. So patients were randomized to receive VTd, auto VTd, plus or minus Dara, and then the first part of the analysis, the first part of the study, stringent CR as a primary endpoint, but also a number of secondary endpoints such as MRD negativity, PFS, and OS. and on a very large number of patients, more than 1,000 patients were randomized into the study.
Huge study.
A huge study. We are seeing that the response is highly increased with the addition of Daratumumab, but also this translates into a better progression-free survival. And we already have, despite a short follow-up of 18 months, we already have a trend for a better overall survival. So this, for the first time, may indicate that we need to use Dara or a CD38 antibody in the setting of stem cell transplantation. So we will have additional data soon coming from Europe because we have exactly the same study design with VRD plus or minus Daratumumab, the Perseus study.
Right.
And I guess that in the near future, we will propose a quadruplet in the setting of stem cell transplantation, including a monoclonal antibody.
Yes, it does look like this is moving towards becoming a standard of care. And obviously we have other data with the Dara VMP and the non-transplant setting.
That's it, in fact. We had in the non-transplant setting the VMP plus or minus Dara, the Alcyone study. We are going to discuss about MAIA, Lendex plus or minus Dara. So Dara is useful in the relapse setting, but I think that importantly, it can be also very useful as part of frontline treatment.
Yeah, so what's your take on this, Joe? I mean, we have the quadruplet, we have the triplet. How do you see this moving forward? How are we going to be selecting our treatment here?
Yeah, I mean, it's challenging in one respect. I mean, congratulations on a great study, by the way. I mean, I think this is so important to the myeloma community.
A huge study completed rapidly, as you mentioned.
Absolutely. You know, I think there may come a time where we're going to be giving quadruplets to everyone, but I think the timing is interesting with MAIA, as you've shown, Brian. The way I look at it is, you know, we have three major classes of drugs: the proteasome inhibitors, the immunomodulatory drugs, and the monoclonal antibodies. And historically, we took one of each of those first two, added steroids, and treated patients who were going to transplant. Then eventually we started doing the same for transplant ineligible. I think what MAIA is teaching us now is, out of these three, you can basically take your pick out of two of them. So you look at our patient factors, what's convenient to them? Do they want a more oral regimen? Do they have certain features that may sway you to one or another? I think we're getting a little bit of a signal that if you have high-risk myeloma, maybe you should probably still choose a proteasome inhibitor as at least one of the combination. And so if MAIA gets approved in the US, which we suspect it will be in the near future, docs can basically, with their patients, choose two out of those three until we actually start going with all three plus a steroid, that quadruplet. So I think this was sentinel work, and I think, as you've mentioned, once we have the Dara VRD, I think most of us feel that's probably what we're going to do in the majority of patients before transplant. And those who aren't going to transplant, where they may have more comorbidities, we may go to the choose two out of the three kind of model.
Right.
What is interesting in the MAIA study is that we had more than 40%, almost 40% of the patients that were older than 75 years. And the feasibility of Lendex Dara is very good. And we had a presentation at ASCO about the subgroup of patients older than 75 years. And the PFS is identical to that of the younger patient population. It means that we can propose this combination very easily to very old patients with myeloma. And now that we will have also Dara sub-Q available, it will be quite convenient to have the Lendex plus Dara combination. And if we are looking at the PFS analysis, we can anticipate that the median PFS in the Dara arm of the study will be better than 50 months.
Yes, it's going to be.
Those results are achieved currently with stem cell transplantation in young patients. So, I mean, this is really a game changer.
Yes,
no, I agree. This is really a major step forward. And as you know, having improvement in the older population has been difficult. And so this is a true step forward. A treatment that is tolerable and providing this degree of benefit.
And it's the first study, the MAIA study is really the first study ever to take two out of those three and give them indefinitely. Even in the SWOG study that you led, that with bortezomib and lenalidomide, the bortezomib had a defined period of time.
Absolutely, because
Here
it's not
in
possible
MAIA,
to
that's
give.
right. It's not possible to give it long term. Here, I think that's one of the reasons why we're seeing such a great outcome. Not only do people tolerate it well, they're on it for longer, and we hope that if we start incorporating sub-Q Dara, you know, a 5-minute subcutaneous infusion is a lot easier than the hours that our patients are now spending in the therapy units.
So just before we move on, just to touch on, so what was your take on the Forte trial? Do you think this will impact our thinking about the duration of the therapy and the role of transplant? We've been thinking about that with, you know, VRD and transplant, you know, whether if you just give it for a little bit longer, perhaps you don't need to do the transplant. Did this influence your thinking in that way?
I think that, well, the data are very important because our colleagues from Italy were able to look at MRD assessment at different time points after induction, after consolidation, and for those patients receiving KRD alone, sequentially after 4 cycles and 12 cycles. And what we are seeing is that the MRD negativity rate is almost identical. That's a little higher with stem cell transplantation. But we don't have any PFS data. So I think that that's really premature to say that we can maybe delay stem cell transplantation systematically. We need to have at least the PFS analysis.
Data. So too soon.
Well, that's too soon, to my opinion. What is interesting is that they were also able to look during maintenance at the sustained MRD analysis, and they are showing that, in fact, some patients that did receive stem cell transplantation seem to benefit more with a longer duration of MRD negativity. So this also may impact our way of designing trials or proposing a duration of treatment based on this sequential analysis of MRD.
Okay, very good.
Yeah, I just, if I can quickly comment, I mean, I think that is such an important point because we thought maybe 12 months of KRD we can abandon transplant. And with the response rate so close, we wondered that. But it's a lesson in being patient and waiting for the results, because if it means that patients get a deep response, that's great. But if it doesn't last, the duration of that response is important. And the early data is a little concerning that more of those patients who didn't get transplant are relapsing. So we can't quite dispense with it yet, but I think we have to wait for time.
And it actually feeds into this next point, which is that there's not a lot of new data about maintenance. It's tough to get maintenance data because you have the long-term follow-up. But this is an interesting study from the German team showing that if you have a benefit with ongoing ixazomib, it's associated with a deepening of the response. And so a correlation between a deepening of the best response beyond a PR or a VGPR, achieving MRD, and then that is associated with the longer PFS. And so